The purpose today is to share an overview of key elements of the Ohio model, including the care delivery model, payment streams, eligibility requirements and timeline, provide a comparison between the Ohio PCMH model and CPC Plus, and walk through the CPC Plus provider application. Commercial and Medicaid managed care plans have made a commitment to Ohio's model and CPC Plus. These plans cover nearly 90% of Ohio's population and about 10 million covered lives. As you know, Ohio has been developing a PCMH model designed to improve primary care in Ohio. One key feature of the model is that it is inclusive. Every Medicaid member will be assigned to a provider. All providers will have to apply and meet specific enrollment requirements, which we will discuss in more detail in a moment. We plan to launch an early entry version of the model in January 2017, and then the model will be open to all eligible practices in Ohio in January 2018. Here you can see the activities that many of you are doing already to keep people well and hold down the total cost of care. High-performing practices told us these are the key components required for high-quality, individualized, continuous, and comprehensive primary care. The problem today is that practices are not paid in a way that supports these activities. We want to turn that around and financially reward those of you who go the extra distance to engage patients, keep them well, and avoid unnecessary costs. For those of you who don't yet have these capabilities, we want to create a practical path toward becoming a patient-centered medical home. The Ohio PCMH model has 3 enhanced payment streams for primary care practices that meet 3 categories of requirements. There are 8 activity requirements, which include things like 24/7 access and risk stratification of your patients. There are 5 efficiency measures, such as ER visits per 1,000, and 20 clinical quality measures. This is significant that we got all of the payers to align on one core set of measures tied to payment. Practices that meet these requirements get access to 2 payment streams. First, an additional per member per month payment to compensate practices for the activities that we believe improve care. Second, a shared savings payment to reward practices for lowering total cost of care while still meeting quality, efficiency, and activity requirements. Also, we're considering practice transformation support, but that would be highly targeted and only available to a limited group of practices. Enhanced payments would begin in January 2018 for any primary care practice that enrolls in the program and meets the requirements. As I mentioned, we want Ohio's PCMH model to be as inclusive as possible. These are the only limits on participation. Any primary care practice with at least 500 Medicaid members across all of fee-for-service and managed care is eligible to enroll. Unlike some other programs you may be familiar with, national accreditation is not required, and neither is an electronic health record. This timeline illustrates how the Ohio PCMH model builds on the comprehensive primary care demonstration in Southwest Ohio, which is set to expire at the end of this year. We were preparing to invite the current CPC Classic sites into our statewide model as early entrants in January 2017, and then the federal government announced CPC Plus. Now our plan is to launch with an early entry cohort in January of 2017 that is open to any practice selected into CPC Plus that has 500 plus members, practices with at least 500 Medicaid members with claims-only attribution and NCQA Level 3 accreditation, and practices with 5,000 Medicaid members and any national accreditation. Then in January 2018, our program opens up to any practice that meets enrollment and activity requirements. This is important because any practice not selected for Medicare CPC Plus will still have an opportunity to enhance their revenue through Medicaid and the commercial plans. Now let's take a look at CPC Plus in more detail. CPC Plus is a new payment model that CMS announced this spring that aims to reward value in primary care for Medicare beneficiaries. The scale is much larger than the CPC Classic demonstration. CMS intends to select 5,000 practices within 20 regions across the country. There are 2 tracks for providers in CPC Plus. Both tracks require the practice to be a high-functioning PCMH, but Track 2 transfers additional financial risk to the practice. Practices apply for Track 1 or Track 2, but may be accepted into the program under Track 1, even if they apply for Track 2, if CMS believes they cannot be successful in Track 2. We believe CPC Plus complements the work we've done already in Ohio. Our care delivery model is based on similar principles to those in CPC Plus, and our payment streams and requirements are also highly aligned. There are a few differences that I want to mention. For example, we define practices based on tax ID number, and CPC Plus is based on individual practice sites. Ohio's incentive payment is shared savings rather than the pay-for-performance bonus proposed in CPC Plus. CPC Plus includes partial capitation in Track 2, and in the Ohio model, our alternative to fee-for-service ties to the episode-based payment work already underway. As a quick aside, we currently have performance reports going to the specialist primarily responsible for 13 episodes of care. We plan to design 30 additional episodes this year, and the goal is to convert that information into referral reports for primary care. One last difference between our model and CPC Plus, our quality metrics include pediatrics and several other measures that are not directly related to Medicare, so not included in CPC Plus. Here is a high-level timeline for the CPC Plus application process. We organize all of the state's Medicaid managed care plans and 4 largest commercial payers to submit a similar application proposing the entire state of Ohio as a single CPC Plus region. CMS will select regions for CPC Plus around the end of July. If Ohio is selected as a region, which we think we will be, then practice applications are due by September 1. We are working on a template application for providers that we will make available to help guide practices through some of the details, sorting out things like how CPC Plus and other federal programs like advanced payment models and Medicare shared savings programs fit together. CMS will select CPC Plus practices if they can keep to the schedule by the end of the year, for payments starting in January of 2017. That's also when we plan to launch early entry into the Ohio model. I want to specifically thank the plans that worked with us to submit applications that are extremely well aligned. In addition to this list, I'm aware that Summa and Akron and possibly others use the same template to apply. We believe our strong organization and focus communicates to CMS that Ohio has the multi-payer participation to successfully support CPC Plus. There is one last comparison we want to make between Ohio's approach and CPC Plus, and that's the proposed reimbursement. Think of it like this. Ohio and Medicare are highly aligned on the activities we are willing to support with enhanced revenue, but our specific approach to reimbursement is different, and that's allowed by CPC Plus. You'll notice that the Ohio Medicaid fee-for-service and Ohio Medicaid managed care payments are identical. The Medicaid director sets these reimbursement levels for the plans. Medicare fee-for-service has lower panel size requirements and higher PMPMs, and as mentioned before, the payment stream design is slightly different. CPC Plus has pay for performance rather than shared savings and includes a partial capitation in Track 2. The column for commercial and Medicare Advantage is blank because these decisions are all made at the individual plan level. One last thing we wanted to cover, the CPC Plus application. There are 43 questions in the application organized into these 11 core elements. We include a complete list of these questions at the end of this presentation. If you are considering applying for CPC Plus, you should review the application in detail as soon as possible. There are some requirements, like a letter of support from your EHR vendor, that may take some time to complete. CMS provides some useful provider resources for CPC Plus applicants, including a comprehensive set of frequently asked questions and detailed program requirements. If you have any questions about Track 1 and Track 2, I encourage you to review the program requirements. Most practices will not be ready for Track 2, and that's important to understand when you apply. Here are a few examples from the frequently asked questions. For the Medicare Access and Chip Reauthorization Act, MACRA, Alternative Payment Model Track, CMS has not given a definitive answer on whether CPC Plus would count as an APM, but has given some indications that this might be the case. For the Medicare Shared Savings Program, participants are eligible for the CPC Plus model. Dual eligible members are included in the CPC Plus model, except for those in a demonstration project like Ohio's MyCare program. This is notably different from the Ohio PCMH model, where we allow any practice that meets our model requirements to participate, regardless of participation in other programs. In a moment, we will open the discussion for any questions you have, and if there are specific questions you want us to address to CMS, please let us know. The next 4 slides go into more detail about the questions in the CPC Plus application. This is here for your reference. Here are the next steps you can expect from the state of Ohio. We will communicate the status of the payer CPC Plus application and hopefully announce CMS has selected Ohio as a CPC Plus region in July. We will create and share an Ohio-specific provider application template for CPC Plus, and we will assist to answer questions regarding the application as necessary. We will try to address some of those questions now, and you can email questions as you think of them to Monica Yanger. Thank you for taking the time to understand the connection between the Ohio model and CPC Plus. We believe this is a real opportunity to provide a necessary boost to advanced primary care practices, and we look forward to being partners with you in that effort going forward. At this point, we'd be glad to respond to your questions.
Okay, we will read off the first question we have here. Is CPC Plus enrollment limited to practices with 50 or fewer clinicians?
We've received this question from a number of people. The short answer is no. Enrollment in CPC Plus is not limited to practices with fewer than 50 clinicians. There is a limitation of 50 or fewer clinicians in part of the recently proposed MACRA rule. On May 9th, CMS released the proposed rule, now open for public comment through the end of June. It covers the Medicare Merit-Based Incentive Payment System, or MIPS, and Alternative Payment Model, APM, incentives. Our read of the proposed rule is that for practices that have more than 50 clinicians, there's nothing to prevent them from participating in CPC+, and there are still real benefits to doing so. But those practices don't automatically qualify for advanced APM under the third criterion in the rule. Additionally, it seems you can still apply to an APM under the regular MACRA requirements for models beyond medical home models. We encourage folks to review the proposed rule and, if interested, provide comments to CMS no later than June 27th. Comments can be submitted to CMS either via email or mail. You can find out more information about MACRA, MIPS, and advanced APMs at cms.gov.
Next question. We strongly believe that PCMH pediatric practices should be allowed to participate in the CPC Plus initiative. Can practices like ours be partners with you in advocating with the federal program to allow pediatric practices to be involved?
Yeah, the state's view from the beginning has been a very broad definition of primary care practices, of course including pediatrics. We do have an open line of communication with the federal team that is implementing CPC+. We've had an open invitation that as practices in Ohio identify issues that you're commenting on, probably directly to them, do let us know those positions, and we'll collect those and share them ourselves with the federal team. However, at this point, although there may be some design changes in the CPC Plus approach, it may be unrealistic to believe that some significant changes are going to occur at this point.
Next question. Does the 500 Medicaid patients include Medicaid as a secondary coverage, and does it include the Medicaid HMO plan?
This is John. On the 500 number, it does not include Medicaid as secondary coverage. It would have to be Medicaid as primary because that's tied to our total cost of care models. But it does include managed care. So it's 500 lives across both fee-for-service and managed care.
The next question we have is, can we get a listing of the patients assigned to our tax ID number from Medicaid?
Medicaid is currently working on the attribution of patients across the program, and when those details are finalized, once practices have gone through the application process, that information will be shared.
Okay, this is a lot of information all at once. We appreciate the time the folks on the phone have taken to run through this with us. We are going to record this webinar and post it on the website, and would encourage you that as you are aware of folks who are interested in this, please do forward that link. We do want to make sure we get the word out that even though we don't know for sure yet if Ohio is a region, we think it's going to be, and we do want folks working ahead to be prepared so at the right moment these applications are ready to go in. As I said, I think this is a real opportunity to give a significant boost to advanced primary care in Ohio. We're glad that thanks to the work of many of you on the phone and the payers over the past 2 years, we feel like we're prepared not only to step up to the opportunity, but to take these next steps with some confidence. So again, thank you to everybody, and we look forward to working with you in the future.